give it to Dr. S K Poddar sir for the first part of the CME.
Thank you, Dr. Chauhan. I think, as you said, I am a DMA also. They are basically not for CMEs also. And what Physician Forum of India is doing is tremendous. No organization in Delhi has done. That's what I can say. I don't know outside Delhi. So many CMEs, so many quality CMEs with all the best speakers. So again, today we have one of the best speakers, Dr. Vineet Malhotra. He is a very famous urologist with special interest in andrology. We have heard his many talks on andrology. He has over 22 years experience as urologist and andrologist. He was trained at MPUH Nadiad, Gujarat. He is one of the best urology hospitals. He is expert in penile prosthesis and also microsurgery for urology. He is board specialty member of National Board of Examinations. He is also convener of Andrology section of USI, Urological Society of India, and also co-convener of Andrology section of Indian Fertility Society. So there are so many, I think, awards given to him. But just to give one thing more, he was invited as faculty in many international and national meetings on andrology. And today he will speak on URO-LIFT. At present, he is director and founder of SCM Clinic at Vienna Hospital, very near to this place. And he will speak on URO-LIFT. URO-LIFT is a new procedure for benign prostatic hypertrophy. Let us hear from him. Many patients of BPH are basically managed by medicines, oral drugs, and very few are requiring surgery. So it's a procedure in between medicines and surgery. Let us hear from the expert where he can fit URO-LIFT into the treatment of benign prostatic hypertrophy. Dr. Malhotra, please.
Good evening, everyone, and thank you so much, Dr. Poddar sir, for the kind introduction. As usual, it feels always very comfortable to be in front of this forum, one that we've been so fondly a part of for so many years. As Dr. has mentioned, this is, I think, the first small meet that we had was somewhere back in 2007 or 2008. So it was really, really long time back. Today, I'll talk about, the idea was to just introduce this procedure. This is very, very new. In fact, hardly a few procedures have been performed in India. Though worldwide, in a very short span, a huge number of procedures have been performed. And I'll talk about the indications. They have a system, so I'm very happy to tell you that DNA Hospital has been selected as one of the centers where we will be doing URO-LIFT procedures. And thank you, sir. And they have a very rigid system, so you have to undergo that training protocol, and only then you get registered to be able to do the URO-LIFT procedure. So it's a selective procedure. It's not something that's going to happen over all the centers in the country, and they are going to be selective in terms of where these procedures will be performed. We all know the symptoms of BPH. Now, URO-LIFT procedure is for benign prostatic hyperplasia. It's not a procedure for malignancy. It's not a procedure for malignant prostatic enlargement. And I'll talk some, finer details as to where this can be useful. Again, you need to understand, it's an expensive procedure. I'll come to the economics of the procedure later on. But it's not a routine procedure for BPH, which means it's not going to replace nuclear enucleation of prostate or even TUR for that matter. It has a special niche. That niche exists. We know where this exists. We know the group of patients where this exists. So it's going to be applied to that group of patients. The interesting thing is, now, one small thing I'll mention is, back in 2015, there was this EAU in Munich, in Germany, which I had happened to attend. URO-LIFT was actually introduced then, back in 2015. And at that time, it was not a part of Teleflex. Now Teleflex owns the URO-LIFT device as such to use. It was actually a very small company that actually had come up with this device, and they were still looking at where they may use it. I had actually asked them, out of interest, because when you see a promising procedure, I asked them whether we can have this procedure in India. Somehow, unfortunately, we notice this very often that, Asian countries are probably very low in the priority list of procedures where they want to enhance this. So it's taken 2015 to 2019 when the procedure became popular across the globe in select countries, which means US, a few European nations and Japan. That's the boundary of where this extended. And only last year that they actually attempted to register it in the country. And only this year that they've actually now got the registration and have the permission now to do the procedures. And out of a governmental research setting, there's not been a procedure outside that. So that's the kind of progress that it's taken in terms of getting into the country. Now, one of the things, I'm not going to get into this, but if you have symptoms of prostatic obstruction or symptoms that classify for treatment of prostate, now here too it's changed. In the Western countries, the concept of using lifelong alpha blockers versus offering a minimally invasive URO-LIFT procedure as an alternate to alpha blockers on lifelong therapy has become very popular, and patients are allowed to choose through their medical insurance whether they wish to have URO-LIFT as a procedure or continue with alpha blocker therapy. That's not an option at all. And so I spoke to a medical person here. You must sometimes speak to these medical people. They are brilliant people. I won't challenge them. They're usually Ayurvedic or homeopathic physicians. And they question you in terms of what is the medical indication of doing the procedure very frequently. The problem is to explain the cost versus benefit analysis sometimes is a real challenge. And that's really happening with URO-LIFT. We are not getting any medical insurance for these patients. Even in patients where you would think that it is indicated as a procedure, where would it be indicated? Now, these are the common symptoms. You're getting lower urinary tract symptoms and you're getting a possible residual urine that is significant. You're not getting exactly a retention episode. But this is generalized lower urinary tract symptoms with BPH. That's the indication. And that would require lifelong alpha blocker therapy. Where we want to actually use or utilize this is for patients that have this and severe medical conditions. Now remember, as a procedure, if you were to offer any procedure for men that had severe urinary symptoms secondary to BPH and no acceptability of any kind of anesthesia, which means these are severe high-risk cases for any kind of anesthesia, you would not be able to offer too many procedures. You would probably have catheterization as one of the options, long-term catheterization, alpha blockers. Maybe some would say that we would do a green light laser ablation of the prostate under local anesthesia. A very challenging procedure. I don't know how many of you have actually seen a green light laser prostatectomy. We urologists tend to exaggerate our own achievements with different modalities. But if you happen to see a green light laser prostate removal, it's actually a very slow burning of the prostate with a lot of charring. The same thing happens with diode also. Also the same thing happens with thulium also. Now, I was very enticed by certain medical companies which asked me to look at the new thulium laser for prostate. Thulium is an excellent laser for stone. When I used it for prostate, there were no planes that you could identify. It just makes everything brown. The beauty of doing a prostate procedure by laser is that you are able to identify the white capsule from the fluffy cotton-like prostate material. You can only do that if there is no charring. Unfortunately, when I used the thulium laser, everything was brown. The prostate was brown, the capsule was brown, everything was brown. So you had no idea where you went. And then I asked all the experts in the field, considering that I was a very novice person into the field, that, tell me I must be doing something wrong. They said, there's nothing wrong. You have to just assume that whatever you see is that capsule and then go into that plane. We don't like to work on assumptions, which is why I never think thulium or KTP, green light or diode are the appropriate lasers to treat prostate. Holmium still remains the choice because it does not cause any color effect onto the prostate, which means it doesn't lend any color to the prostate, and you are able to differentiate between cotton wool prostate and the capsule which is fiber-like. Now, considering that, I would be at a disadvantage to offer these procedures like a KTP to a patient under local anesthesia. So what option would I have in such patients? This is the option to offer. And I'll show you how the procedure is. So, it's a minimally invasive procedure. Beta, यहाँ सामने से नहीं जाना।
आगे से नहीं जाना। बेटा इधर से आप कैमरे के आगे मत आओ।
It's a minimally invasive procedure to treat an enlarged prostate in patients that are looking at alternative options for medication or major surgery. It's very important to remember this. We have never considered an alternative to medication. Remember this. In our country, if you can do with medication, surgery is out. That's a rule, it's a given. The patient comes to you and says, किसी भी तरह से मेरी इंसुलिन बचा दीजिए, मेरे को टैबलेट से काम करा दीजिए, या किसी भी तरह मेरे को टैबलेट दे दीजिए, मेरे को सर्जरी मत कराइए. That's the bottom line that we normally see, But this is the premise that is being accepted by medical insurance outside our country. Our country doesn't accept it, but it's accepted by medical insurance outside our country. That if it replaces lifelong medical therapy, then it is an acceptable way to treat, and that's one of the indications. The other is that you are able to do major surgery without the need of anything but local anesthesia, which means you can do this procedure under local anesthesia. It's safe and effective. The risk profile is far better than other procedures. I'll show you a short animation of how this procedure is done, and you'll be surprised how this procedure is done. It's actually so simple. It's simple in terms of the procedure as you see it, though there are certain calculations and certain maths to the procedure that make it challenging for certain situations, like say an enlarged median lobe or a very high bladder neck. And it's not, and one of the other major advantages of this procedure is there is practically no incidence of retrograde ejaculation or sexual dysfunction with this procedure. Now again, a small anecdote. I can't help but do with anecdotes. I got this gentleman from somewhere in Africa. I think it was Nigeria or maybe Congo. And he came in for a procedure. We get gentlemen from African nations for prostate procedures. They have huge prostates. They have huge organs also, by the way, but they have huge prostates. So he came for a prostate procedure. We explained everything to him, and we did a prostate procedure. And a month after the prostate procedure had been done and he went back, he called me up and he says, "Doc, I am horrified. I had sex last night and I had no ejaculation, and my life is over." And I thought my life was over because there is no way that I can now return his ejaculation to him. Once I've done a prostate procedure, there is no way he's going to get an ejaculation again. So now, for the next many months, I was counseling him as to how prostate procedures end up in having total retrograde ejaculation in more than 90% of men, especially if you're doing something like a URO-LIFT, where you remove the entire prostate right from the capsule. There's no way you can have any ejaculation which is antegrade. Everything goes retrograde. So that made us develop ejaculation preserving procedures. So we started doing a few enucleations which allowed ejaculation to be preserved. But it was a concern in a lot of men that if I were to have a prostate procedure, I would still want to preserve my ejaculation because it's not about the reproduction. It's just that for me, normal sexual function means the ability to not only have intercourse, but also to be able to ejaculate. And if I'm not able to have that, I will lose my desire for intercourse. So considering that this is actually a procedure which allows us to maintain the ejaculation antegrade and have a normal sexual function. Some amount of heat that is generated out of a TUR procedure or a laser procedure also leads to a transient sexual dysfunction. This does not at all. And this is how the procedure is done. So you use a normal cystoscope. In fact, what the company has done is tied up with another company called Scholli, which is also a German company, which has devised a special cystoscope for them. This cystoscope is a long cystoscope.
Do we have a video of this?
I will.
Okay.
I'll show you a video of this, but I'm just explaining the procedure so that you can understand the video well. It's a long cystoscope which allows the instrument to be passed through it. The lobes which are enlarged are actually pressed by this scope to one side before you shoot the trigger. So you have these triggers that you shoot, which then allow placement of sutures. And when these sutures are placed, they are held in place by what we call staples or holds on the capsule and the surface of the prostate. So they actually compress the prostatic lobe. When you compress the prostatic lobe, you open up the prostatic urethra. It's as simple as that. It's actually, lift is one term that you can use. Compress is another term that you can use for this. So it actually compresses the prostatic lobes within that stapling device.
Cut and tie.
So it's kind of a cut and tie, but it's got these two clips at the end and the suture that tightens them within. And that's how this procedure works. It's as simple as that. You just have to understand where to fire. If you know where to fire, you can actually clip the prostatic lobes. And depending on the size of the prostate, you use 3 at least and 6 or 7 staples at most, which means you are able to treat a prostate between 3 to 7 of these implants. So this is what we see before the procedure, which means you have lateral lobes that are obstructing the prostate, and this is what you see after the procedure, which means an unblocked urethra after the URO-LIFT system procedure. And I'll now quickly come to the video which has been provided by Teleflex for this, but this is actually a very useful device. So I'll just show you how the procedure is done. And so this is a cystoscopy which is done. Once you've done the cystoscopy and seen an obstructed prostate, you go in with the cystoscope right across the bladder neck. You engage the URO-LIFT device, withdraw it and compress the prostate on a side, then fire. The first trigger releases the suture which goes outside the capsule of the prostate. The second trigger releases this implant at the capsule of the prostate, and the third trigger will release this implant end at the prostatic urethra. So you've compressed with 3 trigger fires and opened on one side. You repeat the procedure on the opposite side, and again 1 trigger, 2 trigger and the third trigger, and you've got the prostate. So you can see how widely it has opened.
Very good.
Similarly, procedure repeated at multiple levels. You can do this for median lobes. You can do this for procedures that have large prostatic. The cutoff right now for prostatic size is 100 gram prostate, which means you can treat up to 100 gram prostatic enlargement with a URO-LIFT procedure. You can do it under local anesthesia. You do not require to use anything but local anesthesia for this procedure, which is another huge advantage of this procedure over other procedures. Now, one of the indications that has been used in older men, they are somehow recommending it not to be used in men below 50 years of age. 40 is their absolute cutoff. So this is before and after a URO-LIFT procedure. And one of the things that they've said is not to use it in men only with a high bladder neck if you are early into your practice. Because that actually, so if you remember, if there is no prostatic enlargement, but your obstruction is because of a high bladder neck, the placement of this implant is very tricky. There's actually a 4-quadrant placement that they do in that case to actually pull the bladder neck down. And it's not such an easy placement. So there are more advanced ways of using the URO-LIFT in certain tricky situations. Otherwise, as a standard procedure in most men that have high-risk disease, this is a great procedure. Now, what's the flip side? Every procedure has a flip side. Cost is the first major flip side. One implant costs 1,45,000. That's just the cost of the implant. Which means, now that's the MRP, and even consider what cost you put in. But if you were to use 3 implants, which is the average number of implants that are used in Asian subcontinent, which means that we would consider the third world countries for that reason. We would look at a cost of about 4 lakhs just for the implants and add the surgical cost to that. It's an expensive procedure. It's not an inexpensive procedure. You may require to put more. It's rare to require to put less. So you may require to put 2 implants. If you're very lucky and get away with 2 implants, you're still looking at a cost of 3.5 lakh rupees for the procedure. So cost is the major prohibitive current disadvantage to the procedure. And I think till we start getting a regular insurance approval for patients that are indicated, which means high-risk patients with these indications requiring this procedure, because they will never give it for patients that want to preserve sexual function or ejaculation. It's only the high-risk patients that possibly will get this recommendation. We should be able to do this procedure in them.
How long the patient stays in the
hospital? I'll now conclude my talk and we can take some questions. Thank you.
I think we'll have questions after the Dr. Abhishek's talk.
Thank you, sir.
First we'll have questions on your talk, then Dr. Abhishek.
Sir.
So I request Dr. Malhotra to introduce our
To prostatic surgery. I saw Lalit raising his hand.
one by Dr.
Yeah, go ahead.
So I think, thank you Dr. Vineet for introducing to this audience a new method of treatment for BPH. I think basically what BPH does, an enlarged prostate compresses the prostatic urethra, and that's causing obstruction to the urinary flow. And what URO-LIFT is doing, it is compressing the prostate, and the side, practical side is reduced, and it relieves the obstruction. Am I right, Dr. Vineet? So enlarged prostate compresses the urethra, and lift compresses the prostate, and that becomes practically smaller in volume, and that relieves the obstruction. So it's a new method, but before doing it, you must rule out, I think, cancer prostate. So by all means, PSA, or you do routine biopsy also for.
No, sir. We don't do a routine biopsy as we don't do for other benign prostatic procedures. One more advantage which I didn't mention in this talk is, over a period of time, this causes fibrosis of the prostate. So it's just not a compression, but eventually even a reduction in volume of the prostate.
In long term, it will actually cause fibrosis.
I don't know, should I answer one question preemptively, because
Yes, sure.
danger questions come from this audience. A question that has been asked is, can you remove this? It's a very important question, because at times you may need to remove the URO-LIFT. So you can't remove the entire URO-LIFT. You can remove the prostatic urethral part of it, and you can remove the suture. So we need to cut the tips of the implant that edge the prostatic urethra, and then pull as much suture as possible, but you cannot remove the implant that's held on the capsular end. That always remains as a problem.
And the most, I think, beautiful part is it doesn't cause retrograde ejaculation as OLAP or other.
Absolutely.
So I think question, yes, Dr. Paras.
First of all, I would like to congratulate our Nadu friends. Very nicely done, both of them. Dear, I want to know from you, this looks very tempting for me to apply the same in the obstructive sleep apnea setting.
Tonsil baby, sir. Adenoid baby.
Now, ask your company people whether we can apply the same clipper to take the palate away. To take the
Sir, मुझे एक चीज बताइए, आपकी कैप्सूल कितनी स्ट्रॉन्ग है वहाँ की? This is the important question, and I tell you why. Because the holding factor to this entire thing is the fact that the prostatic capsule is a very tough capsule. It allows this implant to compress. If you have a soft capsule, it doesn't work.
Your talk reminded me that yes, in tonsil also we similarly want to have the defining capsule, and thereby we do the surgery. As you very rightly said, that something which blurs the boundaries, we don't know what we are doing.
No, sir, not only defining, sir. It's got to be tough to hold a compressive force.
Hard object.
So now my questions are two. One, what is the dimensions of the clip you are using? How broad, how wide? Second question, after this surgery, does it lead to any urinary incontinence?
No, not at all. So the sphincter lies beyond the apex of the prostate, and we don't apply any clips beyond the prostatic lobe itself. So no incontinence. The length of the implant is about 1.5 centimeters. So that's
That is quite big.
It is.
Quite big.
So the length of the prostatic urethra is between 2.5 to 4 centimeters.
Tonsil capsule again, similarly stiff, so it can hold.
Dr. Thakur has a question.
I've got two questions, small questions. One is cost of implant. Cost of implant.
I told you, sir, it's about.
Yeah, I heard. I just wanted to clarify myself. You were saying 3 implants cost around 6 lakhs or.
It's about 1.45 per implant.
One implant means what? Pair of implant? Because left and right, both implants are being put.
So when you trigger one implant, it has one clip on the capsule and one on the urethral end and a suture in between. That's one complete implant.
Thank you. And the second thing is regarding instruments. As you said, electrical ejaculation is a problem and people lose their interest in sexual activity. So how are you going to convince insurance companies to include this in insurance?
Sir, in fact, you are telling many insurance companies are paying for it.
So I'll tell you how it is. Sexual side effects are impossible. You can only justify it for currently in our conditions for a patient that is absolutely medically unfit for any other procedure. So if you have a patient that is absolutely, and I have a patient who has 18% ejection fraction, has just recently had a CCF, is in retention of urine and does not wish to have a catheter. Now he is a patient who cannot receive any anesthesia. Under local anesthesia, this is the only procedure that can get him catheter free. So I will apply for insurance. What has happened is, even insurance companies, they tend to be selective, which means what they have done is they will reimburse 80%. They may not reimburse the entire cost, but they will reimburse 80%, which is good enough. So you convince, and this family comes to you, that's an affording family, has this gentleman who's 89 years old, has many comorbidities, very high risk for any procedure. This has no risk at all. It's nothing at all. It's like doing a procedure, like doing an endoscopy, or even not even an endoscopy, like doing upper, laryngoscopy or something like that.
Last one, a small question. What is the recovery rate? Is there any difference between the conservative, the previous surgery and this surgery?
So, very, very nice question, because I'll tell you, everything has a flip side to it. And I recently got a patient that came in with a failed URO-LIFT procedure. You know, marketing is a different thing altogether, and then the reality is a different thing. So, we are still in the judgment mode. I can't answer this question because outside of India, in these three countries, 400,000 procedures have been done for URO-LIFT. 400,000. That's Japan, US and 2 European countries. But can you imagine that in the last 3 years they've done 400,000 procedures? We've not had any. We've had 3 procedures, and that too in research conditions.
How much you have done?
But if you've done, no. We are not allowed to do any procedures in practice till, so they have their protocol, which is a good thing. I always like this, where they say that we will assess you for 20 procedures before we allow you to do it on patients in your practice. And that's what I've just enrolled into their system. So I'm very happy that our hospital has enrolled into their system, but I have not done a procedure in my hospital. I am still under training from them. Answering your question, sir, this is a procedure which has been done in abundance there. We still get, I have a patient that's come in with this request to have an alternative procedure after a failed URO-LIFT procedure. So there will be procedures that will fail, but we have to identify the right indications, and that's true for everything. It's not just for this. It's true for when I do a procedure like a shock wave treatment for an ED, or if I put an implant for a patient, I have to identify the right indications where this procedure will be useful. I think we are still going to learn. I hope that what they mentioned, which means in these high group of high risk patients where we were not able to offer, I have a lot of patients who are on permanent catheter. No, you can't do anything, either on SPC or PUC, that's their life for now. If I'm able to replace that with a URO-LIFT, I hope it is that group of patients, 90-year-old, that I can put a URO-LIFT and he can be catheter free for life. Not wanting to change his catheter every 1.5 months. He doesn't come with recurrent infections. He doesn't come with the fact that he has to change of catheter. So many things. Antibiotics lifelong at 90 years of age. I'm hoping that it fits that group of patients. At least then it's actually useful.
One small last question, 5-second question.
Sir.
As you said that you have done a few surgeries, a few implants. You must have been trained and you must have read.
I'm undergoing that.
I'm saying. You must have read also by Google and all the by your journalists. Did you manage to find any complication of the implants?
Thankfully not for me.
No, not
But
for you. You are-
but there are known complications. You can fire the implant in wrong positions.
Not for you, but in general.
Yes,
Food,
there
that's we
are.
are talking about food.
Yes, there are.
Yeah.
If you fire the implant in inappropriate locations and there have been pelvic hematomas with absolute injuries to vessels also. So, if you are doing now, one of the brilliant things about them is what they have set as a rule now. I think they learned also. They would have had some complications, that's why they set these rules. But now they don't permit you to even do it in an unsupervised situation for the first 20 cases at all. Which means they would have had their share of complications. And in their complications, hemorrhage was one of their biggest complications that they faced. And so, there are complications to the procedure. Now they happen much less. Even the cases that I will do after my training is complete is going to be supervised for the first 20 cases. You know how they supervise it? Which means somebody who's done 1,000 cases is going to be on a virtual video call, this thing with me, and is going to observe my endoscopic procedure also when I'm doing it. That's the rigor now of doing the procedure, which is very good. But I think what it also tells us is that they had their share of complications.
Sir, Dr. Vineet, what a wonderful talk, and we learned many things. Just a few comments and few questions, sir. Firstly, I would remind my friends if they have seen रज़ाई कैसे सिली जाती है, पहले इतनी मोटी होती है, फिर उसमें इधर से ऊपर से धागा खींच के और उसको सही कर दिया जाता है. It is just like that, and it is not equivalent to breast conservation therapy surgery. It's no surgery. Sir, my first question is versus URO-LIFT and comparison to resume the water vapor therapy. How frequently you do either of them?
So I have not done resume. Frankly, I have not done any resume at all. URO-LIFT is a procedure that I have just got. So again, because of the fact that I got introduced to, actually even resume and around that time also, but resume came through another company and Teleflex did approach. So I am kind of, using this procedure. For the invasiveness of the procedure, I think this is a far less invasive procedure than the rest.
I leave most of the questions for Dr. Tulsi. My last question is, just like we have, it's a food for thought. Like we have stents for coronary artery, whenever there is a collapse, to give a stent. Whenever there is, even for tracheal stenosis, we have stents. It's a stenosis in the urethra due to whatever, outer pressure, whatever. Are we thinking of urethral stents in cases of...
urethral stents have been around for ages.
So are we developing on them?
Even prostatic urethral stents have been around for ages. The problem with urethral stents has been two. One, there has been a problem with urine reacting with the stents. Now remember, blood does not react with the stents. But urine, unfortunately, has a lot of chemical baggage with it, and that reacts with the stent. We've seen that with DJ stents, which are placed in the urine system. You can't place them for, and we tried to create long-standing DJ stents. But even then, in spite of all our efforts, encrustation, hardening, breaking of the stents, that happened with the urine in the DJ stent. Similarly has happened with the stents, whether they've been put in the ureter or in the urethra. The second problem is that when you actually then have this overgrowth of tissue into the stent and you need to remove it, it's impossible without causing severe damage. So, if you actually had a situation where you developed an obstruction in a stent that you placed, it was a dreaded situation. The final thing was this length of the stent is very variable because the prostatic urethra lengthens as the prostate grows. So every person will require a different measurement of urethral stent. It's very difficult to differentiate the length of the urethral stent. There's so many challenges. They've been around for a long time. unfortunately never got popular.
I get your point, sir. I say they started from bare metal to drug lifting to absorbable. That
Yeah,
will
doctor,
take over.
because we have to a question for Dr. Sheikh also. Yes.
So, Dr. Vineet, what a fascinating talk. I'm actually pleasantly surprised that this modality has been approved in US FDA since 2013, and such a capable neurologist and urologist like Dr. Vineet hasn't done any procedure as yet. Well, to proceed, randomized clinical data has been presented in peer-reviewed publications saying that the procedure is safe, very effective, and has been endorsed by not only the American, the European, and the Indian Urological Association as well. So, ejaculation dysfunction is improved with this as compared to worsening of the ejaculation dysfunction with the gold standard TRP. Just a word on that.
So I don't use the word improved. Again, even though FDA approved it very early, we didn't get the procedure, and I'll tell you, and it was a very sad experience, because this is something that I realized when we visited, say, the Munich conference, like 2014, they actually introduced it into Europe. Asian countries, especially India, is not part of their plan. So whether it was Resume, which was also introduced in the same year, or it was the URO-LIFT, which was also introduced in 2014 in Munich, they just didn't want to introduce in India. Economically, it did not make sense to them. And in spite of the fact that URO-LIFT was actually done by a German urologist by the name of Thomas, who happens to be a very, very close friend and a colleague, we actually trained together. But, and in spite of me inviting him to come and do the URO-LIFT procedures in India back in 2015, they just didn't have India in their plans. It did not make economic sense for them. So it's just one of those very distressing things. You want to introduce something, you've been behind them, but they've not entertained you because of the fact that it doesn't fit into their economic picture. One of the reasons behind it is, now I'll give you the example of implants also and URO-LIFT also. URO-LIFT is covered by medical insurance in the US for all costs, which means they cover the entire costing behind. Imagine that if I were to be in US suffering from BPH, I can undergo a URO-LIFT procedure just by saying that I don't wish to have medical therapy for life. I want to have a non-medical therapy option. I can choose a URO-LIFT and get covered by my insurance. And India does not cover that at all. It's a huge difference in cost. So, there are economics that works behind this. Coming to your second question about ejaculation. Ejaculation is not improved by URO-LIFT, it's preserved. So it's one of the ejaculation preserving mechanisms. Why is it an ejaculation preserving mechanism? Now to understand that, we must need to know how ejaculation happens. Ejaculation has 3 steps. One is called emission. What is emission? Emission means that there is a spinal impulse for the seminal vesicles to contract and put the semen into the posterior urethra. The next step is closure of the bladder neck so that no semen goes inside the bladder. And the third step is contraction of the pelvic muscles, which means the bulbo and the corpus spongiosus, which allows antegrade ejaculation. This is the ejaculatory reflex. If any of these steps is disturbed, you get retrograde ejaculation. That's what happens with all prostate procedures and even with medications. If you use alpha blockers, you open the bladder neck. And so the second step where the bladder neck closes does not happen and the semen goes into the bladder. The URO-LIFT does not affect the bladder neck, and so the closure of the bladder neck happens, and so you have preservation of antegrade propulsion.
You know why I said ejaculation dysfunction is improved? Because many of our patients, before you go through the URO-LIFT, have been on alpha blockers. have been on
So that answers your
alpha reductase inhibitors. So when they stop this, automatically it would improve. But having said that, when you employ this URO-LIFT, how long do you continue with the alpha blockers? Maybe 1 month?
So the URO-LIFT,
I believe so.
the URO-LIFT actually gives you an instant improvement. That's what I mentioned in the talk also. You can actually measure the improvement within weeks, and you actually don't need to continue the alpha blocker even for a month. That's the kind of rapid response you get. Alpha reductase inhibitors have no effect on this. It's the alpha blocker. Because the alpha blocker controls the relaxation at the bladder, and that's the one that makes the difference. And you can stop the alpha blocker within a week's time.
Right. So what can go wrong with the URO-LIFT?
Oh, a lot.
The placement?
A lot.
Tell us. Hemorrhage.
Hemorrhage, if there is abnormal placement, you can have an ineffective placement also. So let me tell you.
Absolutely. So what can go wrong with the URO-LIFT is the apparent placement of the
So we call it ineffective
implants. Yes.
Absolutely. And particularly, this is more common. Now if you have just lateral lobes, it's not so difficult. You know, you just press the lateral lobe and you get it. But if you don't have too much of the lateral lobe,